Dear students, I am Professor Dr. Reda Saad, Professor of General Surgery in Shams University in Upper GIT unit. We will discuss the neoplastic esophageal diseases. By the end of this lecture, you will be able to correlate the different pathological types of esophageal cancer to its predisposing factors and clinical presentation. You will be able to select the proper investigation for a patient having suspected esophageal lesion and to outline the management of a potentially curable esophageal cancer and the methods of palliation. One important thing for esophageal surgery, it should be done in a specialized unit to get the best results. Most of esophageal diseases present with dysphagia, and it is very important to differentiate between the types of dysphagia to reach the proper diagnosis. This management or the management of these esophageal diseases requires collaboration between medical and surgical specialists. Why we should treat esophageal disease in specialized units or centers? Because the usually patient having esophageal disease or neoplasm present late. He has two types of cachexia. Cachexia from the malignancy, what's called malignant cachexia, and the cachexia from inability to swallow, from the dysphagia he has. Also, we have difficulties in management because of the anatomy of the esophagus, as discussed before, being long, passing through three different compartments, neck, chest, abdomen, being devoid of serosa, and one peculiar thing here is we don't have end-to-end anastomosis in the esophagus as compared to the small intestine or large intestine. To start with benign esophageal tumors, they are rare, occurring mostly in the middle and distal third of the esophagus and usually asymptomatic. Leiomyomas are the most common intramural tumors. It tends to grow progressively and cause dysphagia. It appears as indentation of the lumen of the esophagus by contrast study, and it should be excised if the patient presents with dysphagia and for potentiality of malignant degeneration. Malignant esophageal tumors. We know that the esophagus is lined by stratified squamous epithelium. So we expect to have squamous carcinoma, which is the commonest and was the commonest. But we have, unfortunately, another type called adenocarcinoma occurring in the lower third. And it is probably derived from metaplasia discussed before, what is called Barretts esophagus, which occurs after long-standing chronic reflux. So we have squamous carcinoma and we have adenocarcinoma. In the past, squamous carcinoma was considered the commonest, about 50%, and adenocarcinoma was about 30%. Nowadays, more or less, they are equal. Even adenocarcinoma now having 60% incidence, more common than the squamous carcinoma. We have another rare type of malignancy, malignant melanoma, less than 1%. Sometimes sarcoma, adenocystic tumors are very, very rare. This slide shows us the progression of gastroesophageal reflux disease to adenocarcinoma. Starting upward by the gastroesophageal reflux, heartburn, long-standing reflux lead to metaplasia, changing of one mucosa to another from squamous to columnar, and then progression to low-grade dysplasia, high-grade dysplasia, and ending by invasive esophageal adenocarcinoma. These are also the sequences of progression of Barrett esophagus ending by adenocarcinoma. These are the endoscopic views. From the left, this is the normal, passing to Barrett, and then ending by the fungating lesion in the lower end of the esophagus, adenocarcinoma. Tumors of the gastroesophageal junction is totally different. We have special classification for it called Stewart classification, and it will be discussed in the face-to-face session. It is a tumor of the esophagus. Carcinoma are aggressive. It occurs mostly in the lower third in 50% of cases, 40% occurring in the middle third, and 10% only in the upper third. It's spread by direct through the wall and invades nearby organs. Lymphatic spread to lymph node in the neck, chest, or the celiac lymph node in the abdomen. Blood spread is rare to the bone, brain, or liver and lung. Also, we have what's called peritoneal implantation. Sometimes it occurs. Macroscopically, we have the fungating lesion obstructing the lumen, the ulcerating lesion causing hematemesis and bleeding, stricture and polyp discovered by endoscopy. Regarding the epidemiology and the etiology, it occurs after cancer, colon and stomach. Concerning the incidence, male are more common than female, 2 to 1. It is uncommon before the age of 50. Uncommon, but it happens. The disease usually is advanced by the time of presentation, having a mortality up to 70% within 1 year. 8% only survive 5 years. The predisposing factor to squamous cell carcinoma is different from that of adenocarcinoma. For squamous cell carcinoma, heavy alcohol intake and smokers are the main predisposing factors. Others like stricture, achalasia, esophageal whip, esophageal diverticuli are rare predisposing factors. For adenocarcinoma, we know the only predisposing factor detected is the Barrett esophagus on top of long-standing reflux. Carcinoma of the esophagus is more common in China, Far East, and in the Caspian Sea due to some fungus which grows on food grain. The tumor presents either de novo or on top of pre-existing benign condition like GERD, achalasia, diverticulum, or corrosive strictures. It presents by dysphagia. This dysphagia is painful, gradual, starting by solid and late dysphagia to liquids. Hematemesis sometimes it occurs, and infiltration to the recurrent laryngeal nerve leads to hoarseness of voice. Respiratory tract infection and the cough from the aspiration or development of tracheoesophageal fistula. By examination, physically, general examination, only in advanced cases, you will find wasting, cachexia, sometimes liver enlargement because of metastasis, and left supraclavicular lymph node verrucous in advanced disease. We have to investigate a case of dysphagia or pain on swallowing odynophagia in any middle-aged or old age by endoscopy. Any patient presenting with these two symptoms, we have to proceed directly to gastroscope and to take biopsy if any lesion detected. Barium swallow is indicated for carcinoma of the esophagus to diagnose the site of the lesion being in the cervical portion, thoracic portion, or in the abdominal part, and usually the tumors appear in the form of stricture, and this stricture as seen here in the middle third of the esophagus being about 4 centimeters long and irregular. So the stricture in the malignant esophageal tumor differs from that of the benign condition being irregular and happening anywhere. This is to compare this stricture from that of achalasia as discussed before. After diagnosis of malignant lesion in the esophagus, we have to stage it. We have to know if this tumor having metastasis to the liver, to the lung, having extension outside its lumen, which means local invasion. This should be done by CT scan of the chest and abdomen. Sometimes we do staging laparoscopy or thoracoscopy for detection of any infiltration. Endoscopic ultrasound is a new tool. It demonstrates the depth of invasion, what is called the T stage. Also, lymph node infiltration, which is the N stage, and this is very helpful in diagnosis of curable or non-curable disease. PET scan is very important for any metastasis. This slide shows us the infiltration or the staging of the tumor passing from T1 to T4. N denotes lymph node metastasis from N0 to N3, and M for metastasis, M0 if there is no metastasis, M1 if there is distant metastasis mostly to the liver. To manage a case of esophageal malignancy, we have to define whether this treatment will be curative or palliative. Palliative treatment is indicated if the disease is so advanced with metastasis, if the patient's general condition is very bad and can't tolerate any surgery, and if infiltration to big vessels or the trachea exists. So, very important, even that if the tumor is impossible to cure it, we have to what is called to restore the esophageal lumen and to relieve the obstruction so the patient is allowed to eat and to drink and prevent saliva aspiration. So the choice of treatment depends on the patient fitness, chest and heart condition, and the stage. So to start the management, I have to investigate the chest and heart conditions by ECG, by echo, by pulmonary function tests. Very important to check this condition. Surgical resection of the tumor is only indicated when the aim is cure. So the management or the latest management of tumors of the esophagus for carcinoma is to use what's called neoadjuvant technique. Neoadjuvant therapy means chemotherapy is given alone or in combination with radiotherapy, which is called chemoradiotherapy, before surgery in an attempt to shrink or downsize the tumor. This is followed by surgery, and then after surgery we give adjuvant therapy. Adjuvant therapy, this means that we start by doing surgery and then to be followed by chemo or radiotherapy, or both of them. Radiotherapy nowadays tend to be reserved for incurable patients with dysphasia as a palliative procedure to restore swallowing, such as argon, plasma, tissue coagulation, laser treatment, etc. To start by surgery, as we said before, it is indicated if the aim is to cure the patient. We have 3 questions to be asked: what to resect, how to reconstruct after this resection, what organ to be used, and where I will put this organ, which means the route of reconstruction. The choice of the operation depends on the level of the lesion. So if I have a tumor, I have to remove the tumor with an appropriate safety margin, to do 2-field lymphadenectomy, which means mediastinal and the abdominal lymph node should be removed with the primary tumor, and to achieve a good anastomosis. So according to this aim, we have what is called 1-field esophagectomy, 2 fields, and 3 fields esophagectomy. For curable tumor which involves the middle and upper third of the esophagus, we usually do what is called 2 or 3 stage procedure: total or subtotal esophagectomy and esophageal reconstruction. The 2 field or 2 stage esophagectomy in the form of Ivor-Lewis operation and transhiatal esophagectomy. In the Ivor-Lewis operation, we do laparotomy and right thoracotomy, as seen in this picture. In the transhiatal esophagectomy, our aim is not to open the chest, so we do abdominal incision, laparotomy, and cervical incision for the anastomosis. For the 3-field esophagectomy, we have laparotomy, thoracotomy, and cervicotomy to do the anastomosis. The details of this operation will be discussed in face-to-face session. The most important operation performed nowadays is the Ivor-Lewis, which means laparotomy and right thoracotomy for tumor of the lower 2/3. The transhiatal esophagectomy, which is a 2-field esophagectomy done aiming not to open the chest and to avoid any mediastinal problem and even any respiratory complication, but it is not a curative or radical operation because the dissection around the esophagus is done blindly. We don't remove any lymph node in transhiatal esophagectomy. The 3-stage is a curable, definite, radical operation. We open the abdomen, the chest, and the neck. In the abdomen and the chest, we can do associated lymphadenectomy to reach the radicality of the operation. 1-stage esophagectomy is to resect lower end tumor, either with subtotal or total gastrectomy, and to follow by what is called esophagogynostomy, either simple loop or row on Y. So after resection of the esophagus, I have to choose one of these organs to replace the esophagus, either the stomach, the colon, the jejunum. We prefer the stomach because it involves only one anastomosis and rich in vascularity and without any contamination. We prefer the posterior mediastinal route because it is the shortest. Nowadays, we don't do any subcutaneous, what is called pre-sternal route. Sometimes in some specialized unit, we do what is called hybrid esophagectomy. We combine either laparoscopic approach with thoracotomy or thoracoscopic with abdominal approach, so we can achieve the dissection of the esophagus and the anastomosis by many invasive techniques. Esophagectomy is not an easy operation and it is not free of complication. The most important is respiratory and leakage, and in some cases this complication could be fatal. So I have to inform the patient before the operation about these risks and complications. Palliation for inoperable lesion. So if I decide that this lesion is inoperable, I have to choose one of the palliative measures like chemotherapy, radiotherapy, which could be an external beam, or sometimes implantation by radioactive substance inside the esophagus, seeds or castor. But we prefer for palliation what is called stenting, to use self-inflated metallic stent to be inserted through the stenotic segment or the stricture segment. It is done by using endoscope and by intravenous sedation. And I have to instruct the patient after insertion by using to use food which is liquid and to drink a lot after eating to keep it clean, and to use PPI for reflux. This is the end of your recorded session. please be ready with your questions in the face-to-face session. Your face-to-face session will start with simple questions related to the content of this presentation. I'm expecting all of you to be ready. Thank you.